Dr. Netra SS, Professor and Anesthesia, Professor of Anesthesia Department, BMCRI, Bangalore. Madam has done her UG in JSS Mysore, PG in JJMMC Davangere. She is having a teaching experience of 26 years and publications of 28. She is present Secretary ISA Bangalore Metro Branch, past EC member of ISA Karnataka for 6 years. She is a scientific committee chairman of SZISACON 2019 and organizing secretary of Difficult Airway Workshop 2011, ISA of Difficult Airway Workshop 2015, ISA Research Methodology Workshop in 2016, and 3 CMs in BMCRI. Over to you, ma'am.
Hello, good afternoon everyone. Today I'll be talking about post-operative visual loss in non-ophthalmic surgeries. Warm greetings from Bangalore Medical College and Research Institute. I don't know how many of you have encountered this complication. In my experience of 26 years teaching experience, I have not seen any case of post-operative visual loss. Probably a devastating complication which alters the day-to-day life of a patient's life. It is defined as either partial or complete visual loss that occurs post-operatively in non-ophthalmic surgeries. This was first reported in the year 1948 in a patient who had optic globe injury. He was posted for surgery and he had a post-operative vision loss. This was due to improper position of his head on the headrest. The incidence is 1 in 60,000 to 1 in 1,25,000 in general anesthesia. So before going on to in detail of post-operative visual loss, we'll just see the highlight of the blood supply of optic nerve. As we all know, it receives a blood supply from the ophthalmic artery, which is a branch of internal carotid artery. The branches are posterior and anterior ciliary artery and the central retinal artery. So it and the venous supply is from the central retinal vein, which drains into the ophthalmic venous system. So the risk factors are, it is mostly seen in males and with the comorbidities, and in patients with anemia and wherever patient is undergoing prolonged surgeries, hypercoagulability, embolism, all obesity, or in all these patients we can see the post-operative visual loss. The surgeries associated with this are, it is commonly seen in spine surgery followed by cardiothoracic surgery, and next is head and neck and veno-venous bypass. The other surgeries are in patients who is undergoing upper abdominal surgery, laparoscopic surgery and robotic surgery. So we probably might see in TURP also. Pathophysiology of post-operative visual loss. In patients having coagulation disorder, decreased arterial supply, and in surgeries who is having anemia, hypotension, hemodilation, and patients undergoing prone surgeries with prolonged duration, all these in all these patients they might have increased venous pressure and decreased venous return, which causes increase in intraocular pressure. We all know that intraocular pressure range is between 12 to 20 millimeters of mercury. Under general anesthesia it increases, under general anesthesia it will be around 15 to 20, whereas in prone position after induction it increases to 27 millimeters of mercury. In prolonged surgeries during extubation it increases to 40 millimeters of mercury. If the intraocular pressure increases to 60 millimeters of mercury, there is no blood supply to the optic nerve. So the types of postoperative visual loss are ischemic optic neuropathy, retinal artery occlusion, cortical blindness, and miscellaneous like corneal aberration, acute glaucoma, then transient ischemic attack, and TURP glycine toxicity. These are the sites of postoperative vision loss. We can see from this slide, the posterior ischemic optic neuropathy occurs in the posterior part of the optic nerve, anterior occurs in the anterior part, central is seen in the central part of the optic nerve, and corneal aberration is seen in the cornea. So the incidence of Types of postoperative visual law. American Society of Anesthesiologists on Professional Liability, they established a postoperative visual law registry in the year 1999. Here they had a series of postoperative vision laws. So in that they included 131 cases. Out of these, only 93 cases met the inclusion criteria. Among these, 83 had ischemic optic neuropathy, 8 had ischemic optic neuropathy unspecified, and 10 had central retinal artery occlusion. Coming to ischemic optic neuropathy, this is the commonest cause and it is seen due to impaired blood supply to the optic nerve. This is seen commonly in spine surgery, cardiac surgery, head and neck surgeries, and ENT, and the that is sinus surgery and orthopedic surgery. Usually they present with irreversible, painless loss of vision which occurs spontaneously without any warning signs. There is relevant afferent pupillary defect. If this is absent, we had to take an MRI or CT scan to confirm the diagnosis. The types are anterior ION, where the blood flow is disturbed to the anterior part of the optic nerve. In the posterior ION, the ischemia is there to the posterior part of the optic nerve. There are two types, that is the difference between AION and PION are, in the presentation in AION they have initial normal vision which is followed by painless loss of vision which might be unilateral or bilateral. In PION they have painless loss of vision which is usually bilateral. The visual complaints and examination, they both have similar things, whereas in fundoscopy in AION there is edematous optic disc followed by flame-shaped peripapillary hemorrhages. In PION they have the fundus is normal in the early stage, later they have optic nerve pallor. The risk, the AION is seen in cardiac surgeries, whereas in PION it is seen in spine surgeries. Retinal artery occlusion. The cause is it occurs due to embolism, ocular trauma, improper patient position, and vasospastic diseases. Whenever there is a thromboembolism or direct pressure on the globe, external eye compression, this causes increased in intraocular pressure, decreased oxygen carrying capacity, and impaired blood flow, leading to postoperative visual loss. Usually they present with sudden painless loss of vision which is monoocular. This is seen both in children and adults. This condition is irreversible. So I told you that there are two types, central retinal artery and branch retinal artery occlusion. In central retinal artery, there is decreased blood supply to the entire retina, whereas in branch retinal artery occlusion, it affects only a portion of retina. Both these conditions are ophthalmic emergencies and it is analogous to acute stroke of the eye. The fundoscopic examination in CRAO, this shows the red cherry spot at the macula, and there is pale optic disc and pale fundus with thinned out vessels. In BRAO, there is cholesterol or the calcific emboli or migraine pale emboli of platelet and fibrin. So, central retinal artery occlusion following spine surgery is referred to as headrest syndrome, as it is due to the use of horseshoe shaped headrest. Cortical blindness. Whenever there is decreased perfusion to the occipital cortex, secondary due to hypertension or emboli, causes the cortical blindness. This is seen following surgeries with high embolic load like CABG or in spine or joint orthopedic surgeries. The presentation is they have painless loss of vision ranging from partial to complete. Peripheral vision loss if it is bilateral. If it is unilateral, they will be having contralateral homonymous hemianopsia. Total recovery is rare. The fundoscopic examination usually here normal. This can be prevented by maintaining the perfusion pressure hematocrit about 30%. Posterior reversible encephalopathy syndrome, that is PRES. So the theories are failure of cerebral vascular autoregulation, which causes cerebellar hypertension, leading to vasogenic edema. The other theory is cerebellar vasospasm, which causes ischemia and decreased supply to the optic nerve. So this is seen in the acute illness, that is severe hypertension, immune suppression, chemotherapy in obstetric cases like preeclampsia and eclampsia. So this is seen following spine surgery, hysterectomy and VATS. So they present, usually they have slightly decreased perception or complete blindness. Onset of vision, it usually does not occur immediately post-operatively. It takes hours to days, and usually they have loss of vision, which is, and with other non-specific symptoms like nausea, vomiting, loss of consciousness and seizures. Treatment is asymptomatic. Corneal aberration. This is seen when the eye sustains direct injury to the eye. It is a self-limiting process, and it increases the risk of inflammation and infection. Usually the patient in this condition, that is in corneal aberration and acute glaucoma, they will be having painful loss of vision. So this is accompanied by the tearing, foreign body sensation and photophobia. On examination, they will be having aberration in the cornea, or a foreign body can be seen on inspection with fluorescent staining. Acute glaucoma, this is very rare, and whenever it occurs, the pupil is mid-dilated with pupillary block. If it is uncorrected, it increases the intraocular pressure and may lead in optic nerve damage. So this also, as I told you, it has painful loss of vision, usually seen in elderly females, accompanied by headache, nausea and vomiting. So the treatment is immediate ophthalmologic consultation and measures to decrease the intraocular pressure. If this is not, if the IOP cannot be reduced, you can do the peripheral iridectomy. So management, as this slide shows that we have to, if the patient is having postoperative visual loss, we should immediately call the ophthalmologist or the neurology department and take a consultation. And if the patient is having ION, so elevate the head end of the bed, correct the volume depletion and increase the arterial pressure. Drug like acetazolamide, furosemide and mannitol, it might be beneficial, but steroids and hyperbaric oxygen, it is controversial. In retinal artery occlusion, systemic thrombolysis can be done if there is no contraindication. Ocular massage is controversial. Acetazolamide may be beneficial. These two conditions is irreversible. If there is no ION or PR or RAO, treat the underlying cause. So this is the as per the ASA advisory. So this was they had published in 2005, which was amended in 2012 and again in 2020. So as per this advisory, the summary is preoperative patient evaluation and preparation. So we have to do thorough preoperative evaluation and identify the comorbidities. If the patient is having any comorbidities and if the patient is undergoing prolonged surgeries, we have to explain to the patient, and returned informed consent should be taken, and we have to inform the possibility of postoperative visual loss. Intraoperative management, continuous blood pressure monitoring should be done. If there is hypotension, for the prolonged hypotension, we have to treat it, and if the surgeon requires hypotensive technique, we have to discuss with the surgeon on case-to-case basis, and treatment of prolonged hypotension should be done. Management of blood loss and administration of fluids. Periodic monitoring of the hemoglobin values during surgery should be done in high-risk patients. Blood transfusion as deemed appropriate. Crystalloids and colloids for replacement of blood volume. I'll take 2 minutes. So use of vasopressor to treat the hypotension. So patient head and positioning devices. whenever the patient is undergoing surgeries in prone position, the head should be elevated above the level of the heart, or a 5 to 10 degree reversed Trendelenburg position should be given. Head to be neutral, fixed forward without significant neck flexion, extension, lateral flexion or rotation when possible. So I avoid direct pressure on the eye to avoid CRAO, and check the position of the eyes periodically during surgery for any compression, and document it. Use a mirror to view the eyes. Some of the articles says that we can use the gel foam head resting, but some of the articles says that also doesn't prevent the postoperative visual loss. Staging of surgical procedure is very important. This should be done on case-to-case basis. Postoperative management period after the surgery is over, in a prolonged surgery, we had to, if we suspect POVL, we had to take a ophthalmologic consultation and fundoscopic examination. If the diagnosis is not made, CT and MRI should be done. So optimize the hemoglobin, hemodynamic status and arterial oxygenation. These are some of the articles which we had gone through, and in all these articles they say that, as I told you about the incidence, and they have told about the cause. If the blood loss is more than 1000 ml, and if there is hypotension, anemia, prolonged surgeries, spine surgeries, they all lead to postoperative visual loss. And the some of the things which can be prevented is by maintaining the hemodynamic status, hematocrit, and avoiding the steep prone position, and staging the surgery. So to conclude, postoperative visual loss, it is a serious complication with medico-legal implication. Hence, multidisciplinary team approach is essential for the prevention and timely recognition of postoperative visual loss. Patients with preoperative high-risk factors and in prolonged prone position should undergo preoperative and postoperative ophthalmologistic consultation for early detection of POVL. Since prevention of the complication cannot be guaranteed, patients and relatives should be pre-warned about the rare risk of POVL, and informed written consent should be taken. These are my references. At the offset, I thank the organizing committee of SZISACON South Zone 2023 for this, giving me this opportunity. Thank you.
Thank you, ma'am.